In the last sketch, we took a look at a number of the common CNS tumors affecting adults. This time around, we'll look at the most common CNS tumors to develop in children. There are over 4,000 new CNS tumors diagnosed in children each year. CNS malignancies are the second most common cancer in children, second only to leukemia. Historically, leukemia was the #1 cause of pediatric cancer death. However, advancements in the treatment of leukemia has driven mortality down far enough that CNS tumors have overtaken leukemia as the most common cause of cancer death. CNS tumors have a slight predominance in boys, and although these tumors are more likely to be malignant in children compared to adults, outcomes tend to be much better for kids than for their older, more decrepit counterparts. Another difference between pediatric and adult CNS tumors is their location within the brain. While most adult CNS tumors form above the tentorium cerebelli, aka supratentorial, the majority of pediatric CNS tumors develop below the tentorium, especially in the posterior fossa and cerebellum. Welcome to Camp Astrolake, where we'll be spending a night under the astrocytes. There will be medulloblastoma s'mores, campfire games like Appendimoma Pictionary, rafting in the aqueduct of Sylvius, pilocytic stick forts, and, of course, no summer camp experience would be complete without a few craniopharyngioma pranks. It's gonna be great. We went over the common manifestations of CNS tumors in our previous sketch, which usually arise secondary to intracranial hypertension or mass effect of the tumor compressing surrounding parenchyma. The most common include headache, seizures, and sometimes focal neurologic defects. If intracranial hypertension is present, signs include headache, nausea, vomiting, and papilledema. Well, remember that in children, primary CNS tumors are most commonly infratentorial, i.e. under the tentorium cerebelli, i.e. right in the cerebellum's hood. This means pediatric CNS tumors are especially likely to show so-called cerebellar symptoms. This includes nausea and vomiting. Well, remember that in children, vomiting is like one of their favorite things to do, making it super nonspecific. But you might also see gait problems, ataxia, as well as impaired muscle movement and coordination, all depicted by that zombie prankster kid. Furthermore, young infants can't really tell you they have a headache because of the, let's call it, language barrier. So they usually just display even more nonspecific findings, like poor feeding or increased irritability. Infratentorial tumors can also obstruct the outflow of CSF by obstructing the fourth ventricle, that diamond-shaped ventricle deep to the cerebellum. This causes obstructive hydrocephalus with enlarged ventricles and symptoms of intracranial hypertension. We already have the high-pressure head balloon next to the fire. But let's add in our recurring sketchy symbol for hydrocephalus, a wet rafting helmet with big ventricles. And just as with adult CNS tumors, you can't forget about familial syndromes, which, in children, include tuberous sclerosis and NF1. For more on both of these, check out our videos featuring the neurocutaneous syndromes. Also similar to adult CNS tumors, radiation is one of the most agreed upon environmental risk factors for development of CNS tumors in kids. All right, let's dive right into the specific types of pediatric CNS tumors. First up, a glioma, which should sound familiar. Remember that glial cells aren't the neurons, but the support cells of the brain. The majority of CNS tumors are derived from glial progenitor cells and named for the mature cell type they resemble most. And this first one should sound especially familiar because it's another form of astrocytoma. Pilocytic astrocytomas, so named for the hair-like projections seen on microscopy, are slow-growing tumors and represent the most common CNS tumor in children. So, pylo sticks. Got some projections there even. That works. We've also added an astro pattern to his sleeping bag. Pilocytic astrocytomas are grade 1 astrocytomas, aka benign, aka on the opposite end of the spectrum from the more aggressive diffuse astrocytomas seen in adults. Remember from the adult CNS tumor sketch that astrocytomas in adults are only available in grade 2 and above, the most common being grade 4 astrocytoma, aka glioblastoma multiforme. In this sketch, however, this little astrotech lover is playing with a tiny version of morph, our glioblastoma multiforme crew member from the adult brain tumor sketch. So think low-grade benign version of the astrocytes we've seen before.
Early to bed, early to rise makes a man healthy, wealthy, and dead. Pew, pew, pew!
And what do we have here? A little braff Benjamin Franklin. A majority of juvenile pilocystic astrocytomas contain activating mutations in the BRAF gene, except those associated with NF type 1, causing autoactivation of abnormal cell growth. While BRAF mutations are common to pediatric astrocytomas, they're very rarely found in adults. The most common location of pilocytic astrocytomas is in the posterior fossa and, more specifically, the cerebellum. So again, Remember, we're under that tentorium tent. Grossly, pilocytic astrocytomas tend to be well circumscribed and contain both solid and cystic components. However, these tumors rarely show areas of necrosis, which will help us differentiate them from another tumor commonly seen in the posterior fossa, medulloblastomas. Okay, so pilo, hair-like, and astro, star-like. Suffice it to say that these cells have long processes that extend out to earn both the hair-like and star-like comparisons. A characteristic histological finding in pilocytic astrocytomas is Rosenthal fibers, which are brightly eosinophilic, corkscrew-shaped glial filaments and granular material filling the long processes of tumor cells. Since pilocytic astrocytomas are of glial origin, they stain positively for GFAP, just like their astrocytic adult counterparts. Oh man! Is that the newest edition of the Galactic Federation of Allied Planets comic? Lucky. My parents never give me stuff like that. Unlike their adult counterparts, pilocytic astrocytomas have a very good prognosis and are usually curable with surgical resection. Next up, the second most common cause of CNS tumor in children, medulloblastomas. While they're the second most common CNS tumor overall, medulloblastomas are the most common malignant CNS tumor in children. So not only do we have some medullo marshmallows a toastin', looks like one fell in the fire, making a little blast. That's medulloblastoma. We've also included our malignant cancer crab symbol to remind you that these tumors like to invade into surrounding tissue. Medulloblastomas are small, round blue cell tumors that most likely originate from malignant transformation of cells in the granular layers of the cerebellum. Since they're more differentiated in the neuron direction, these tumor cells stain positively for synaptophysin and neuron-specific enolase, which are normally found in cells of neuronal origin. Synaptophysin? Pfft, more like synapse fightin'. Given their site of origin, it should be no surprise that medulloblastomas are found most commonly in the cerebellum, often extending into the fourth ventricle, still under that tentorium. As the tumor compresses adjacent structures, patients can present with those cerebellar symptoms we mentioned earlier, such as ataxia, loss of coordination, and everyone's favorite, nausea and vomiting. Since they extend into the fourth ventricle, medulloblastomas are also notorious for causing obstructive hydrocephalus, leading to symptoms of intracranial hypertension such as headache, vomiting, and papilledema. That diamond shape is reminiscent of the fourth ventricle that sits deep to the cerebellum. Just FYI. There are several mutations associated with medulloblastomas, including MYC amplification, which confers a poor prognosis. But if MYC signaling sounds familiar, it's because you may have seen it in the Central Park sketch describing neuroblastomas. Other mutations believed to be involved include WNT mutations, better prognosis, and sonic hedgehog activating mutations, on the fence prognosis. Grossly, medulloblastomas are soft, friable tumors that often have areas of necrosis, kind of like these soft, melty, burnt marshmallows, getting all necrotic from the fire. Contrast this with the other cerebellar tumor, pilocytic astrocytoma, which rarely shows necrosis. Under the microscope, medulloblastomas are composed of sheets of primitive small blue cells, which get their name from their deeply basophilic, hyperchromic nuclei and scant cytoplasm. Being an aggressive tumor, it's not surprising to see many mitotic figures as well. In about 20% of tumors, you can find Homer Wright rosettes, which are collections of small blue cells surrounding an acellular pink neuropile. Areas of CNS tissue made mostly of neuronal processes and glia without cell bodies. Yeah, sort of like that ring of blue marshmallows there. And of course, this is another similarity medulloblastomas have with their neuroblastoma cousins, another small blue cell tumor. For more on neuroblastomas, check out the adrenal medulla sketch. It's not uncommon for medulloblastomas to produce drop metastases, where nodules of cancer form along the spinal cord and cancer cells can be found in the CSF. Fortunately, despite its aggressive growth pattern, advancements in treatment of medulloblastomas with surgery and chemoradiation therapy have led to 5-year survival rates approaching 75%. Next up, a brief exploration into what exactly those two kids are doing. Ooh, Pictionary. Nice. Is it two Loch Ness monsters? Let's see here. Flanking a baby pterodactyl head? What? Ventricles. Yeah, I see it now. The third most common CNS tumor in children, ependymomas, are tumors arising from the cells that line the ventricular system. It's like this ependymoma pen outlining the ventricle drawing. Ependymomas are typically diagnosed between 2 to 5 years of age. Since ependymomas arise from ependymal cells, which line the ventricles and central canal of the spinal cord, ependymomas can be found anywhere along the ventricular system. However, ependymomas most commonly grow from the roof of the fourth ventricle, So not only is he pointing to that fourth ventricle, again, we've depicted the cross-section of the fourth ventricle with that diamond shape in the opening of the tent. Ependymomas often block the flow of CSF into the spinal cord, resulting in obstructive hydrocephalus and the classic intracranial hypertension symptoms of headache, vomiting, and papilledema. While intracranial ependymomas are most common in children, they're often found along the spinal cord in adults and patients with neurofibromatosis type 2. Grossly, ependymomas are most commonly solid, tan, well-circumscribed tumors with areas of calcification, hemorrhage, and cyst formation. The most characteristic histological finding in ependymomas is the formation of perivascular pseudorosettes. The bodies of the ependymoma cells form a circle around a blood vessel, perivascular, and grow long extensions toward the center, rosette, sort of like an ependymal cell Ferris wheel with a blood vessel in the center. Taken together, the picture looks like a ring of cell bodies around a central blood vessel, with pinkish eosinophilic cell processes in between. Fun fact, these are known as pseudorosettes because, technically, the central blood vessel is normal tissue and not a true empty lumen. Neato. Keeping with the rosette theme, another finding in ependymomas is the formation of ependymal rosettes. These are caused by cancer cells clustering together and, being ependymal cells, attempting to form a ventricle. This leads to an empty lumen in the center of a ring of ependymal cell bodies, a true rosette. While not always present, these are diagnostic of ependymoma. Unfortunately, ependymomas have a poor prognosis due to their tendency to disseminate throughout the CNS, making complete surgical removal difficult. We're going to take a break from all the bashing of the posterior fossa for a bit and talk about some supratentorial CNS tumors seen in children. The most common supratentorial CNS tumor in children is the craniopharyngioma. You may remember craniopharyngiomas from the pituitary sketch. Craniopharyngiomas are benign tumors made up of epithelial remnants of Rathke's pouch, a division of oral ectoderm that ultimately forms the anterior pituitary. So look, we've brought back the craniopharyngioma punching clown from the pituitary boxing sketch. Remember that these tumors are usually found above the sella, where the pituitary normally sits. Also, on histology, these tumors classically display solid, cystic, and calcified components, depicted on that cystic, calcified face of his, still as creepy as ever. Craniopharyngiomas account for between 5 to 10% of childhood CNS tumors, and usually present with unique signs and symptoms, such as bitemporal hemianopia due to compression of the optic chiasm, or endocrine dysfunction, e.g. panhypopituitarism due to compression of the pituitary gland. Check out the pituitary dysfunction videos for more info. Let's finish up with one more supratentorial tumor found in children, germ cell tumors. As it would turn out, germ cell tumors don't always end up in the gonads and can even form tumors in midline brain structures. Why germ cells in the CNS, though? Well, it's thought that disruption of normal migration of embryonal cells to the gonads during early development leads to midline germ cell tumors, appropriately called extragonadal germ cell tumors. A common location for extragonadal germ cell tumors in the CNS is the pineal gland, causing a pinealoma, appropriately called extragonadal germ cell tumors. Other locations in the midline where you might find extragonadal germ cell tumors include the mediastinum and the suprasellar region in the brain. Specifically, the most common type of primary CNS germ cell tumor is the germinoma, a tumor that closely resembles the testicular seminoma. That means you'll see large round cells with abundant cytoplasm, almost like a fried egg. Check out the testicular tumor tetherball sketch for more details. Pinealomas present with a very unique set of symptoms due to the location of the pineal gland, the posterior surface of the midbrain, right in the vicinity of the cerebral aqueduct and superior colliculi. Impingement of the cerebral aqueduct can cause obstructive hydrocephalus. Just look at that raptor's big fat wet helmet. This leads to intracranial hypertension and the classic triad of headache, vomiting, and papilledema. Compression of the tectum and superior colliculi on the dorsal aspect of the upper midbrain leads to a constellation of symptoms known as Paranod syndrome. Yep, the same vertical gaze palsy syndrome caused in the setting sun sign we went over in the hydrocephalus video, when obstructive hydrocephalus involved the aqueduct of Sylvius. Check out that video for more details. Because their location often precludes surgical removal, the mainstay of treatment for pineal germinomas is chemoradiation. Luckily, they're pretty sensitive to therapy and generally carry a good prognosis. For more on germinomas, seminomas, and all the other germ cell omas, check out the ovarian egg dyeing and testicular tetherball sketches. Well, that's it for pediatric CNS tumors. It's time we headed out of the brain and made our way into the spinal cord. Oh, you're still here. This is awkward.